I've got a few questions for you, for the experts. Professor Burnett, what you have dealt with probably is something that we should call the perfect storm, because a bad patient with a bad cytogenetics is the worst we can have. But what do you expect we can get from the ongoing research for these people?
Well, you know, I do think that that is a subpopulation that does very badly, and one would think that, I think it's premature for us to look for drugs just in that subset, but I think in the trials we're certainly looking for, like clofarabine appears to do, at least we may get lucky and we may find some drugs. I mean, there was a story about amphosphide and clofarabine benefiting that subgroup. In the UK, the physicians generally don't know what the cytogenetics is when they make a treatment decision, which is sort of helpful if you're running a trial. But that's a major challenge, and I think we have to have a very frank discussion with the patient about what's in it for them if it's conventional treatment. There's nothing much in it for them, really. But there may be something in clinical trials, or if we can get hold of an unlicensed drug that we think is useful, that may be worth doing. But it's actually the same in young patients. We've not seen any improvement in adverse cytogenetics for 20 years in young patients. And if a transplant's possible, whatever the age, then that should be considered. And that, to my mind, would be the reason to give them a treatment that's trying to get them into remission.
Thank you. But, it's obvious that to target therapy to a specific molecular abnormality, we need that data on time.
Yeah.
And sometimes it's a bit upsetting, well, especially in the young. You have to hurry up and to give the therapy as soon as possible. But probably it has nothing to do with the elderly population. What do you think about the time frame we have to take that decision, and for how long should we wait for the cytogenetics?
Well, I think that there's some evidence that you don't have to rush at patients who are older with AML. You've probably got 3 or 4, 5 days, maybe even before you can need to start the treatment, but that will vary by patient, whereas in the young patients where it tends to be more proliferative, you probably need to get on with it. I mean, the molecular labs can give you the information fairly quickly, and I think if we required the cytogenetics to give us the key bits of information promptly, they'd probably rise to the occasion. But we've not asked them to do that routinely. You can certainly get FLT3 NPM1 quickly. You could probably get a FISH test quite quickly for complex karyotype or whatever you think is relevant. So, but at the moment, I don't think we've produced the justification to change that whole system yet.
And there is some addition.
Yes, please.
There's a publication of Sekers, I think, who showed that in elderly waiting for 1 week does not result in a much bad outcome for those patient populations. So that's probably due to the more hyperproliferative state of those AMLs, I think.
I think that's a very important issue, because if we want to give the best therapy, and we want to have the opportunity to choose, we need it on time, and probably in some clinical settings, as German AML group, that they work very, very fast. You got it in some 72 hours, but in clinical practice, sometimes you need 1 week or more, and it is very important to know that you can wait a bit more. Please, Professor Balducci.
Thank you. First of all, I congratulate all the speakers for a superb session. Was really outstanding. And in particularly, I wanted to thank Dr. Ossenkoppele for the presentation of that study, that randomized phase 2 study that you're doing in older patients. I think that is exactly the example of where randomized studies have a role in the management of the elderly patient. There is a specific question that is asked, can be asked with the randomized study, and it is done in a, how do you call it, in a dynamic way, so that the study never stops also, I think that was I think that slide should be utilized by this meeting to indicate what the randomized studies can tell in older patients. Thank you.
Then we have to go to the original slide because it was changed a lot by the presentation. It's much nicer.
So we'll come back to Professor Amadori.
Yeah,
we'll have to close
just a word of policy, because we have to ask Professor Morra to wrap up the entire day. So I think we are running late, and I would like to ask Enrica Morra to do his final remarks on the day.